Happy to be joining you again to share the updates and the publication that we have from our missed opportunity study looking at immunization status and barriers to immunizations for those patients who are hospitalized, particularly in our hospital in Edmonton. And as Peter mentioned, we were fortunate to have our project published in Hospital Peds this most recent fall. And this is our collaborative team, and a big shout out to the medical students who were medical students and are now Peds residents that put in a lot of effort along this as well. And so to give a little bit of context for everyone in terms of the setting for this project that took place, because there's some nuances for us in Alberta, where this project took place. The public routine immunizations are only administered by public health nurses. They're not administered in your pediatrician's office or your family doctor, which I know is quite different from some other some other jurisdictions. In addition to that, our immunizations are recorded then in a provincial-wide database, which includes most of our population, though does exclude several populations who live on different reserves within the province. And then within the province, we have our Stollery Children's Hospital in Edmonton, where the same rules apply. Immunizations can only be administered by public health nurses. And at the time that this project was conceived, public health was only available on Thursdays, typically from 1 to 2 p.m., typically required 48 to 72 hours notice. And their mandate specifically explained that they were not to be used to provide catch-up vaccines, rather intended for vaccination of chronic and long-term patients. And so thinking about just our patient turnover, perhaps not right now when no one has bronchiolitis and everyone is medically complex, there's maybe less 48 to 72 hour turnover, but still quite a high rate of turnover. And so even if they were around and didn't, that 72, 48 hours notice is quite prohibitive. Some other statistics that we found last night as we were going through and updating some of our information is we looked initially in 2020, only 78% of 2-year-olds in the province had received a full course of the diphtheria, tetanus, polio, and Haemophilus influenza B vaccine. And then interestingly, that number has dropped from 78% in 2020 to now only 70% as of 2023, based on the publicly available data from the province. And then similarly for the first dose of the MMR vaccine by 2 years of age, in 2020, that statistic had been 88%, and that has now dropped in 2023 to only 82%. So interestingly, seeing some continued decline, and interesting to think about the context of 2-year-olds in 2023 would have been born in 2021. So into COVID, but then starting to see some progression as we got vaccines. So interesting to think about the public health context in that setting. Whenever we talk about vaccinations, the question always comes up, okay, so it's probably just all these anti-vaxxers, particularly in Alberta, and so that's probably the problem. But we know estimates show that only about 2% of kids aged 2 years have not received any vaccines. We don't know the rationale for that, but using that to suggest that it's not the staunch anti-vaxxers who are representing the majority of these patients. And in fact, the majority are a large number of children who are incompletely vaccinated. So that context, along with several challenging advocacy attempts for patients on the ward, led to our objectives for this project, which were one, to determine how many kids admitted to the Stollery truly were under or unimmunized, as we didn't have that data. And then secondly, to identify barriers to immunization faced by families of children who are admitted to hospital. So we developed a prospective study to include all pediatric patients over the age of 2 months admitted to the general pediatrics ward under the pediatric CTU team. We had consent from parents and guardians and assent from all children over the age of 6. We were able to collect immunization data through Connect Care, which is Alberta's version of the EPIC EMR. And then when data wasn't available or incomplete on that platform, which is a whole data sharing agreement issue, we were able to either reference patients' parents' immunization records that they may have had on hand, or contact their local public health unit to update the records and get the most up-to-date information. This included reaching out in attempts at times to out-of-province public health units, if that's where initial immunizations were from. And then finally, our plans were to record barriers to immunization and using a SHOTS survey, which was administered to parents and guardians. And just to give a little bit more context about the SHOTS survey, this is a tool that was developed by Dr. Victoria Niederauser, who's a professor in the Faculty of Nursing at the University of Tennessee, Knoxville. I believe she was at the University of Hawaii when this tool was the inception of this tool, to gain an understanding on the barriers to immunization in a validated way was important to us. And so this tool we'll show you on the next slide some examples of some of the questions, but this was the survey that we used. It looked similar to this. It was in REDCap. We either provided it to families on a tablet where they filled out the REDCap form, or we had paper copies, or we read it out to families based on their preference in attempts to reduce some literacy barriers that may have prevented families from participating. And if English was not the primary language spoke by the families, we had access to translation services where we were able to read out the survey to the caregiver through the support of the translator to collect their responses. The questions are scored from 0, which you can see being not a problem, to 4 being a very big problem. And the questions are divided into subscales and a composite score. And we'll talk about some of that when we get into the results. But the subscales include access to shots, concerns about shots, and perceived importance of shots. So looking at what we were able to do, so recruitment was a lengthy process, and I'll give a shout out to Dr. Kala Isaac, who's on the call, and you'll hear from in a second. It was truly a labor of love with myself and several medical students on our team to approach families outside of clinical duty hours from July 2021 to October of 2022. We were able to get in touch with 250 families admitted to CTU, ultimately based on the number of several surveys that weren't completed or filled out, and several children whose vaccine records we ultimately were unable to verify, including jurisdictional issues such as one child who was immunized out of country, and we weren't able to validate their sources, and a child who also did not provide a cent for us to access their records. We ultimately came down to 230 participants who we were able to access their vaccine records and completed surveys. And the number that some of you may have heard or seen already that is concerning was that ultimately we showed that only 58.2% of our patients admitted to hospital in that category were up to date on their immunizations, which is far below the immunization rates of the general population in Alberta. And to clarify or put some information around this, we had defined up to date on immunizations as the child having received all vaccines they're eligible for on the routine immunization schedule at the time of admission based on the Alberta vaccination schedule. So it did not include the influenza or COVID vaccine. And then the eligibility for vaccines was determined based on the vaccine schedule available at the specific times for each patient. So we have backdated records as the vaccination schedule has morphed and evolved as time has gone on. So things like in September 2018, there was a switch from 3 doses of HPV-9 to 2, and it moved from grade 5 to grade 6. We were able to accommodate for those differences as we were going through the analysis. And so this is our table 1, just looking a little bit more at the demographic information of patients that were included in our project. None of the categories here, so age, sex, rural versus urban location, and length of hospital stay, were statistically significantly different between the groups. Two trends that we noticed were, one, the group of patients tended to be slightly older in those whose vaccines were up to date from those who are not. And we'll show that in a next slide. But we also noted that there was a bit of a trend for the rural population to be slightly more represented in the not up-to-date group, though not significantly, which was certainly a surprise for our group and thinking about our provincial context. And then we also noticed that there was no difference in the length of stay between groups, and then highlighting back to the 72 or 48-hour rule for public health to even come to the hospital, we're going to miss the large majority of patients if their median length of stay is 3 days. Um, so this is busy and not the most elegant figure, but is our showing our vaccination coverage for individual vaccine doses at specified ages of assessment. The categories were selected specifically based on what is reported in the publicly available Alberta Health immunization records. So receiving certain numbers of doses of each vaccine by certain age categories, so that we were able to do this comparison. And so we used the numbers available in the database and then compared them to those available from our project with error bars demonstrating a 95% confidence intervals. We weren't able to do power calculations given that our population is a subset of the greater provincial population that is represented. And we were able to find that those with the star or asterisk above them are the doses where there was a statistically significantly lower immunization uptake in our population, and included the DTaP IPV Hib series, the second dose of the MMR vaccine, the meningococcal C dose at 2 years, the pneumococcal series, and the first dose of the hepatitis B vaccine series. We were also able to see that when you separate patients into groups, which we tried to do based on their kind of primary series and the younger ages, the school years, and then the teenage years, that it trends towards the younger patients as well as the older patients being the two discrepant groups. And I will say, to augment this, when I was going back through the 2023 data last night, the uptake of the HPV vaccine, which would largely be represented in our older two age categories, is between 60 and 70%, but depending on the dose. So reflecting a lot of that in those results. The next part that we looked at was looking more again at those barriers. And so if we remember back, the shots survey had those 3 subscales. So access to shots, perceived importance of shots, as well as concerns about the safety of shots. And the composite score, both between children who are up to date and those children who are not up to date of their parent or caregivers' responses, showed that when we use the Mann-Whitney test, we do see statistically higher concerns about shots in the not up-to-date group than we do in the up-to-date group, both on the composite score, which is what you're seeing here, as well as when this is divided into the 3 subscales. Each subscale, there's higher degrees of concern in those 3. For interpretation of this, the composite score, which is shown on this slide, ranges from 0 to 92, with higher scores representing more barriers. That's just a sum of all of the 0 to 4 rankings for the 23 items on the survey. And the median score for the up-to-date group was 3, whereas the median score for the not up-to-date group was 8. So still on the relatively low end of a scale from 0 to 92, but it is showing us there is some differences. And so really where we were hoping and looking to grow from this project, we ended up finding that, one, as being one of the first studies in a Canadian context, to highlight the disparity in immunization status between hospitalized children and those in the general population, which we found and was similar to what we had anecdotally expected about, but is concerning. And while our jurisdictional immunization rates are below the national target, our hospitalized patients are even lower. There's many current recommendations and different attempts focusing on increasing immunization uptake, largely looking at community-based interventions, but there's been minimal work or attempts thus far to improve access in a hospital-based setting. In building this project, we'd look at a pilot project that had been run out of Children's Mercy Hospital in Kansas that had shown an increase in vaccination status from 73 to 80% in their hospitalized patients, simply by screening the immunization status of patients at admission and then developing an immunization plan before discharge. It's a little bit different in that context, as those children were able to go home and get immunized at their primary care provider's office with contact being made from the study team to the primary care provider. And then there was also a group that showed from New Zealand that showed an increase in immunization as well as re-engagement with a primary care provider in hospitalized Indigenous children in New Zealand. So there's been projects, there's been initial movement that has shown if you address this, if you talk about this in hospital, there's opportunities. I think it'll just the next steps, which we're excited to hear from Katie, Katie's project and others on this call today to talk about how can we as a hospital pediatrics group address this a little bit more. We didn't collect data, and I'm wishing we had, but we didn't collect data on the accuracy of documentation on a child's chart at the time of admission of whether or not the admitting team had accurately identified the child's immunization status was either up to date or not up to date. Anecdotally, I don't think we do the best job of that on our admission, which understandably at 2 a.m. when there's the 19th kid with influenza coming in, that's maybe not the number one priority, but I think it'll be a good opportunity to have some conversation in this group and beyond about what that workflow and what that process looks like. A huge acknowledgement and thanks to the group of those in Edmonton who helped support this project and our funders, both Wickery, the Canadian Pediatric Society Hospital Pediatrics Grant, as well as the Stollery Children's Hospital. And I'm super excited to give a little bit of my time that's left and turn it over to Dr. Kala Isaac, who's a PEDS resident at the U of A now, who's going to talk about a qualitative project that has grown out of this initial project. And I'm just going to swap over our slides to Kala's.
Yeah, thank you, Brittany. Both myself and Dr. Chelsea Gilbert are residents now at the U of A and the U of C, and we initially, as medical students, were working with Brittany on her quantitative project. So we were very inspired by this project, and now that we've separated to two different residency programs, we've decided to try and continue research on this topic. So we've started a qualitative study interviewing parents and caregivers of children admitted to both the hospital in Calgary and the hospital in Edmonton who are unimmunized or under-immunized, and we're looking for barriers that they may face around immunizations. You can go to the next slide, Brittany. Yeah, so there's two residents leading this project, myself at the University of Alberta and Dr. Chelsea Gilbert at the University of Calgary. And we're supported by an amazing team consisting of Dr. Cook, Dr. Constantinescu, Dr. Forbes, and Dr. McDonald. Next slide. And Dr. Lissinna already addressed most of this background information, but I'll just briefly touch on why this is an important topic. We know that childhood vaccinations prevent many illnesses, and we're seeing that at the same time that vaccine uptake is declining, vaccine preventable diseases are increasing. And the stats in Alberta right now are quite staggering, with only 70 to 85% of children in Alberta being up to date on immunizations, and even less, 58% of hospitalized children being up to date. You can go to the next slide. With that being said, our main objective is to learn more about the reasons for underimmunization and the barriers that families and children may face to immunization. And we're hoping to work towards developing system-level strategies to overcome barriers and improve immunization rates, especially in these hospitalized children. Next slide. So what we're doing is a qualitative study, and we're targeting recruiting children that have been hospitalized or admitted to the hospital on CTU teams at both the Children's Hospital in Calgary and the Children's Hospital in Edmonton. We're hoping to recruit about 48 to 60 participants, depending on when we reach saturation of themes from the interviews that we're collecting. We'll have about 24 to 30 participants in Calgary and about 24 to 30 in Edmonton. And we're dividing into two groups, under 7 and over 7, and collecting interviews in both of those groups. The interviews are semi-structured interviews, about 15 to 20 minutes long, asking questions from the parents or caregivers about their experiences with immunizations, things that they think about immunizations, the good and the bad. And we're also at the very end of the survey asking whether they would be interested, if it was possible, to take catch-up vaccines in hospital. After we collect the interviews, we'll be using the transcripts to analyze using thematic analysis and manual coding. 3 of us will be consistently coding between the two sites and coding all of the interviews to try and keep consistency. Next slide. So right now we're in the middle of data collection. We're collecting interviews and we're starting our data analysis. Next slide. This chart shows where we are for participant recruitment. The dark green on the graph shows the number of interviews we've completed thus far, and the light green shows the number of interviews we estimate we'll need to meet our minimum. Because this is a qualitative project, we'll continue collecting more interviews until we reach a saturation point where there's no new themes emerging from interviews. This could mean that we have more or less total interviews in each group. Our estimated minimum is 12, and we now have 12 for the under 7 years group at the Alberta Children's Hospital, which is exciting because now we can go through and look at the themes that might be emerging. And once we do that, we'll start deciding whether we need more interviews. Yeah, and then so far, the study has gone quite well. The main challenges that we've faced are really around recruiting participants. We rely on the admitting teams to recruit participants for us. And I'm sure you all know that there are many competing demands for time for these admitting teams. And sometimes they are unable to recruit participants that might be eligible. So there are some people that are getting missed. As well, immunization is a sensitive topic in our society right now, and some people don't want to participate. So we're trying to navigate around these two things. One of the things that's really helped us is having an RA to complete interviews at both sites. This makes interview completion more consistent, and the interviews can happen during working hours rather than outside of the resident working hours as well. Next slide. And overall, we're hoping that this study will make an impact. One, because it's the first multi-center qualitative study on barriers to immunization in Canada. And we're hoping that it will really help us by enhancing understanding of the barriers that families face to get immunizations. And we hope once we understand that we'll be able to identify strategies for improving immunization rates in our population. And the next slide just goes through some references. And thank you very much for your time.
Amazing. Thank you, both of you. A really impressive residency project, both of you.
I completely agree. That was amazing to hear about some of the work that's being done. And also interesting, I think, to hear about it in a different context as well, because we know that, depending on where you are in Canada, we have different sort of vaccine strategies and limitations in our different provinces. As mentioned by Peter, I'm Katie. I'm one of the pediatricians at Sick Kids. And so I'm going to talk to you about some of the quality improvement work that I did during my infectious diseases fellowship. So we completed this last year, and we're in the data analysis phase of this project. And this work was supervised by Dr. Morris and Dr. Pichet-Renaud. And I am pretty sure Dr. Pichet-Renaud is here as well, so can join in on some of the conversation after I go through my slides. So briefly, I'm going to talk a little bit about missed opportunities for vaccination as a framework. I think it's important for us to discuss, and I think it is what goes into a lot of these types of projects. Afterwards, I'll talk more about our study objectives and our methods. Again, a little bit different because we did it through quality improvement. I'll review the results of our pilot data collection that we completed and sort of the results that we have to share so far. And then I think what I want to do is have some fruitful discussion around sort of next steps in general and what we can do as a network. And so I'll open up the floor to discussion at that point. So I think what's been very clear over the past 30 minutes or so going through these different presentations is that we know that we have poor vaccine uptake across Canada since the pandemic. We know that our levels have not returned to the pre-pandemic levels that we've had of immunization uptake. And really, one of the strategies that's been proposed by the World Health Organization to address decreased vaccine uptake is missed opportunities for vaccination. And so what this strategy really focuses on is shifting the priority around like where is the right place to vaccinate a patient and really using any interaction with the healthcare system as an important opportunity to reduce these MOVs or missed opportunities for vaccination. We also know, and what we talked about already, was that hospitalized children are under-immunized. This is something that we see both in American data as well as the Canadian data. And I have Brittany's data up here. But one of the American studies that did a recent literature review found that between 27 to 84% of pediatric inpatients were overdue for vaccines nationally. And then, of course, the study that was done in Alberta showed that only 58.2% of patients were up to date on their immunizations. So again, well below our national averages for patients or for children in general. So what the objectives were for this project were to use hospital admission to essentially look at 4 different objectives. So first, we were trying to identify and understanding gaps in childhood immunizations. Second, to identify barriers to vaccination. Third, to implement strategies to improve vaccine access and confidence. And then fourth, to facilitate increased uptake for immunizations. And the reason that we chose to do this through quality improvement was because we really, because vaccinations are part of every child's standard of care, it allowed us to actually sort of approach all of the patients on the wards and really interact with all of the families as opposed to, the families that consented to be part of the study. As with any QI project, there's sort of 2 phases. So what I'll be showing is the first phase, which is really that baseline data collection, understanding the different root causes for why we see this issue and completing diagnostics to better understand the issue. And then the second part of the project, and again, I think we'll talk more as a group, is really around improvement, intervention, design, and implementation. So with respect to our methods, we had 2 trained nurses who we were able to hire with some funding, who essentially had extra training in taking a vaccine history to approach all patients who were admitted to our select pediatric wards. So the project ran Monday through Friday. We did not approach patients on the weekends, and essentially the nurses would approach anyone who was admitted to the ward within the past 24 hours. I think for context, it's important to note that in Ontario, one of the challenges that we have is that we don't have a centralized database for vaccination. So documentation is a huge issue. It's very difficult for us to know if patients are truly up to date. It's a combination of like a paper-based system with these yellow cards and also records from family doctors. So there's not a lot of consistency. But we can provide vaccines in primary care providers' offices, and they can be provided in the hospital. So, just some differences again to think about the Ontario context. So for families who had their vaccine information easily accessible, the nurses would collect their vaccine history. Again, going beyond just sort of writing that vaccine's up to date, which I think we see in a lot of notes when patients are admitted, but really looking through, did they get each vaccine at the appropriate time? And then if the child was under-vaccinated, we didn't want to not make a recommendation. So we suggested one of sort of 4 things, either offering the vaccine in hospital, helping to connect to a primary care provider. And then we have our vaccine consultation service at Sick Kids, which is a nurse-based service for patients who have questions around vaccines. So we could refer to that service or to our special immunization clinic if there were questions around actual eligibility for the vaccines. And then for families who did not have the information, we tried to approach them again while they were in hospital or arranged a phone call afterwards if they agreed to that. So I'll show you a couple of the tables that we have from our project, and then we'll talk more about sort of what we can do as a group and thinking more about nationally sort of looking at immunizations. So our project ran, it was mid-December of 2023 until end of February 2024. During that time, there were 207 families that were approached during that period, again, recognizing that families that were admitted on the weekends and discharged in that same time would not have been included. 155, we were actually able to talk to and have our nurses take the vaccine history. In terms of why there's a bit of a discrepancy, we found one of the challenges was that many patients were often off at tests or talking to their primary team. So it was difficult to always talk to all of these families. This first table looks at our demographic characteristics, stratified by those that were fully vaccinated versus those who were incompletely immunized. Again, that incompletely immunized category really is a heterogeneous. Again, not a lot of major differences between the groups. I think one trend to note is just an interpreter use here, that we see that for the incompletely immunized group, there's sort of 16% of the group use an interpreter compared to 7% in the fully vaccinated. And then also just to highlight again, thinking about our population that we see here at Sick Kids, for both groups, about 30 to 40% of patients had comorbid medical conditions, and which were identified by the families. We also looked at immunization completeness, and so here we broke it down a little bit further. So of all of the patients, 68% were fully immunized. Again, this number is sort of below the provincial number of patients that are up to date when it's reported. We had 25% that were partially immunized. Again, I think an interesting group to think about because they have received some vaccines. And then only 3% actually of our patients were fully unimmunized. And then 5% were unsure of their vaccine history and we couldn't get the proper records. I also just wanted to highlight two other vaccines. So we looked at MMRV specifically. What was interesting was that 81% of patients had their first MMR vaccine at 12 months, but this number dropped off. So then we had only 50% of eligible patients between 4 to 6 years who'd received their booster. And then we also did look at COVID and influenza. So 23% of patients who were eligible had completed their COVID primary series. And then 39% of patients who were eligible for the flu shot for last year had received their flu shot. The last two figures that I'll just show you are from a root cause analysis. So what you're looking at is a Pareto chart, which is a tool that's typically used in QI analysis. And really what this chart is doing is allowing us to understand what are those critical few root causes that contribute to the overall issue. So the issue here being decreased routine immunization uptake. So the different bars that you see here refer to the different reasons that families identified as, barriers to immunization uptake. And then the percentages here are the cumulative percentages for the overall effect. And so what we found here when we asked families, and it was similar to the survey that was mentioned for the other study, we had some questions that were yes and no, but we also had a free text option. When we asked families about barriers to routine vaccine uptake, the sort of biggest contributor was around vaccine access, and that referred to families who were talking about, not having a primary care provider or not being able to get an appointment for their vaccine. And I think what I found quite interesting was that when we asked the same question for influenza, which is our seasonal immunization, we actually sort of saw a different spread of answers. So when we looked at vaccine access, it was a much smaller contributor, and our sort of bigger contributors in that top critical few root causes included complacency. So families thinking again that the flu shot wasn't important, and then issues with vaccine confidence in terms of safety of the flu shot, as well as vaccine efficacy. So many families also mentioned, we don't think the vaccine actually works or isn't going to make a difference. In terms of limitations for the study, I think some of the important points to highlight are that the time that the project ran, we only approached patients on 2 different pediatric wards. So we did an initial PDSA cycle on one ward, sort of looked at our data, improved our data collection tool, and then expanded that to look at a second ward that involved patients who were admitted for longer periods of time. So we actually started on our short stay unit and then moved on to one of our general wards where we see longer lengths of stay. The coordination of data collection while patients have active inpatient investigations and management was definitely a challenge, especially on our short stay unit when patients are off getting tests and then they go home quite quickly. Again, in Ontario, there is a big challenge with limited availability of vaccine records. One thing that we're looking at in our data is sort of the accuracy of documentation, because we were, in many cases, able to obtain the official records. So trying to understand what parents reported, is that actually accurate compared to their records? And then many families, once they went home, were quite difficult to follow up on. And so we didn't get a lot of answering when we would call them afterwards. So to conclude, we know that there are significant immunization gaps in hospitalized children. We know that our seasonal vaccines, our MMR, V vaccine rates at sick kids are particularly low. And the rates that we identified at sick kids amongst our hospitalized patients are lower than national averages. And so if we think about some of the studies conducted in other settings, and Brittany actually referred to this Kansas city study as well, which is sort of the second one where they were able to improve vaccine uptake just by asking about immunizations and creating a plan. We've seen that, lots of different institutions, both in Canada as well as in the United States, are looking at better characterizing the vaccinations amongst hospitalized patients and sort of looking at what are different strategies that we can develop to improve vaccine uptake. And so this really brings us to my last slide, which is just talking about next steps and thinking about, because so many different places across Canada are looking at better understanding immunization practices within hospital settings, do we think that there would be a benefit to conducting a national survey to better understand that? And so some of the questions that, we think that we could ask with such a survey would be, do sites have a formal process to capture immunization documentation in hospitalized children? What are the ongoing research and QI projects being done? What are the different practices in terms of how do we deliver vaccines? Again, recognizing that we have different constraints in the different provinces. And what are strategies that we're using to improve vaccine uptake within hospital settings? And again, just getting a more robust understanding of the barriers and facilitators, not just in our own institution, but across the country. So I will stop there. I hope that we can open up the floor for some discussion. And Pierre, I don't know if you have anything else to add as well, but happy for you to chime in.
Thank
Yeah,
you. That
for
was great.
sure.
Go ahead. Yeah.
Yeah, I'll try to be brief as usual, But yeah, to Katie's point, I think we wanted to leave some time for discussion, and then Brittany and Carla, it was great to have you on the call because we definitely saw your paper being published a few months ago. At the time that we were still conducting that work, so we're like, oh, this is quite similar, and we actually presented our work at the Canadian Immunization Conference, at which time Cora was in the audience, Hannah Mitchell as well from BC, and we sort of realized like, oh well, it looks like many of us throughout Canada have a similar interests, so there may be sort of room for potential national collaborations because there may be questions that are interesting to try to address from a national perspective. Of course, within pediatric hospital, we sort of navigate our own immunization environment, i.e., like different vaccine delivery models within provinces, and what you're facing in Alberta with, public health being there only once a week on Thursday between that time and that time is very different than what we have here in Ontario, where we have like more sort of capability to give vaccines, but we do not have an electronic centralized registry to identify immunization gaps, right? So each provinces are facing their challenges, but hopefully, combining our experience together could yield very interesting results, I think. So I guess this is one of the reasons we were happy to present this result and have a conversation with the PIRN network to see if there could be the possibility of doing something, leveraging the network capability around these questions.
Thanks for that background. Yeah, and we thought it's also a nice opportunity to collaborate across disciplines because often there's different expertise among